Okay, good morning, everyone. Thank you for the opportunity to present the case at this conference. And just a little bit about myself. I I did med school in Romania. I came to the United States. I learned English. I worked as a volunteer in a hostel. I went through the USMLE equivalation. I did my surgical residency at Lankenau Medical Center in Philadelphia. And then I was fortunate to do 2 years of trauma critical care at Jackson Memorial Hospital, right, a trauma center in Miami. For the past few years, I've been
it's Lori.
I've been at Kent General Hospital in Dover, Delaware, with Bay Health, and this fall I will be transitioning to Thomas Jefferson University as assistant professor with the trauma division. The case I'm going to present is a little bit of a unusual, unexpected type of trauma. The title is a little vague, but I hope you find this case interesting and challenging as I found it on my post-call day. I'll remember this. This was a Friday. It was around 10 a.m. I just came off call at 7 a.m. and I had a couple of elective cases, a couple of gallbladders, as well as a brachiocephalic AV fistula on the schedule. I just did my first gallbladder, and I was walking through the recovery room, marking my next patient. This is the recovery room at same-day surgery. And I came across this patient encounter with the following information. 57-year-old female, pale diaphoretic, in severe distress. A code blue was called immediately by nursing. With regards to exam, intubation was in progress. CPR started and it was in progress. There were no palpable pulses, and obviously the patient was in extremis. The nurse reports that this patient just arrived from the catheterization lab 5 minutes ago. She was complaining of right groin and right flank pain, and she underwent some sort of angioplasty and stent performed by interventional cardiology. So she had a puncture site in the right groin. Anesthesia was able to successfully intubate after the second attempt. This patient had only peripherals, but the airway and bilateral breath sounds, those were secured. The on-call surgeon was paged. So this is a level 3 trauma center where the surgeon on call does not have to be in-house, so has a response time. So now I found myself, okay, we're on C here. So what location and what type of IV access would you get into this patient? Again, she has a right groin puncture site for whatever procedure was done. The left groin is already punctured profusely by the anesthesia, unsuccessful to place a central line. And what are the potential causes of the arrest for this patient?
Thank you, Dr. Alex. Dr. Rizzoli, your comments, please. Dr. Rizzoli? Dr. Peralta, your comments, please.
Good afternoon, Alex. I thought you were going to be nice in a Monday morning case. Anyhow, it could be a lot of issues. If it's a percutaneous approach, you could have a pericardial tamponade. If they did they can burst a vessel to do that. Also, they could have bleeding through the groin or the for a laceration of the artery when they did that, and the patient has hypotensive, diaphoretic, and the patient had a shock. So those are probably, the issues that I really addressed on her. You say that the chest was clear, good airway entries. So I don't see if anybody has put a central line, from the chest or up of the subclavian. What I do is I put 2 peripheral IV and I start giving blood to this patient quickly, probably. And, this is probably my best approach. I have to do an ABCDE in this lady. Any other injuries, any other hematoma that you see or anything pulsating?
No hematomas, no groin hematoma. And puncture sites from the left groin from other attempts.
And she has, at the time that you see him, that she has a pulse at that time or no?
No pulse.
So she's in cardiac arrest at this moment, no?
Yes.
So you go blue, cardiac arrest. I think that's what I will do. Do the ABCDE and start blood on this patient until proven otherwise. She has probably a bleeding issue. Okay.
Yeah, thank you.
Thank you, sir. Dr. Frisbee, your comments, please.
Well, you didn't say anything about an enlarging groin. You didn't say anything about, a fast exam. So I presume she's pouring into the retroperitoneum. I agree with the rest of the comments. I think you better get the lines open, and the massive transfusion protocol wouldn't be a bad thing to do. But other than that, I think I'd probably do a fast exam just to make sure she's not in the belly somewhere, or I don't think that's what you're describing. It sounds like if her groin is not swelling and the femur still looks like the femur, then most probably she's pouring into the retroperitoneum. But that's all I've got.
Thank you, Dr. Frisbee. And Dr. Calais, your comments, sir.
Okay, I think I agree with all the comments. I put the two peripheral catheters to revolver and start the management of recovery of the cardiac arrest. In these situations, patients have a cardiac arrest. So I agree that can make big use of the fast. The fast exam, you can see the abdominal, if you have fluid or only, and you can see the pericardium. Sometimes the arrest may be tamponated because the injuries of the patient may be during the procedures that she has been done. So I start with the recover maneuvers and recover the cardiac arrest, and then put two peripheral access. That's I do.
Thank you very much, sir. And Sadler, your comments, please. Go ahead, Sadler. You're muted. Lower left of the, there you go.
Oh, say, can you hear us?
Yes, loud and clear.
Sorry, we just got here. We didn't hear any of the previous material on the patient, so we're trying to catch up right now.
Okay, very good. Thank you. Dr. Poos, would you like to comment, sir?
Good morning, everybody. Yeah, I agree with what was already said. You know, there's probably the two main things, either retroperitoneal bleed or cardiac tamponade. Now, the problem is, if the patient is in cardiac tamponade, you're not going to get them out of cardiac arrest unless you release it, most likely. So you wanted to establish that early on during your CPR. So I think one of the very next steps would be to take a quick look with the ultrasound and seeing if this patient is in tamponade, because that will change how you manage this patient from now on. So I would do a quick ultrasound. And regarding the access, yeah, ideally peripheral. And if you can't, you know, if the groins are all swollen up, you know, then I would probably do IJ or something. Subclavian is also an option. The problem is it usually leads to interruption of CPR. So you try not to stop the CPR. So IJ would be one option, or the other is, you know, a cut down on the ankle for the subvenous vein. So, but I'm very suspicious here about cardiac tamponade from a VIA injury during the cardiac cath.
Thank you, Dr. Poos. Dr. Grigsby, your comment, sir.
Yeah, so you know, one comment on this is just, this is a fairly common board question to go into PACU or go into the post-operative area, and patients either hypotensive or you know, in some kind of distress, and they're looking more for like your methodical approach to going through a patient like this. And I like even in patients who are not traumas, I still kind of lean towards ATLS and going through everything. So are they hypoxic? If they're intubated, does their ET tube still work? Do they have bilateral breath sounds? We're looking for a tension pneumo. If this is a cath patient, so we're looking for a you know, bleeding into the retroperitoneum like we're talking about, or a cardiac tamponade. So you know, leaning towards the ATLS algorithm and just the physical exam basis. Listen to both lungs, listen for heart sounds, and then if we've got access to an ultrasound, we can look for things like the pericardial tamponade, that kind of thing. We can look at their lungs and see how they're doing it, and look at the access site and see if we got fluid building somewhere, and then go from there. But yeah, I would make sure our access is good, get fluids going, start thinking about other causes of H's and T's, and maybe, you know, just kind of empirically give them calcium, bicarb, that kind of thing.
Thank you, Dr. Grigsby. Ryder, Dr. Wetstein, your comment, sir? Dr. Wetstein, would you like to comment?
I don't have anything additional to add, just following along for now.
Great, thank you. Dr. Hakeem, would you like to comment, sir? You're muted, sir. Down in the lower left corner. Okay, great, thank you.
Got it, yeah. So the comments till now are, absolutely fine for the patient, but I just have two things to say. One, that I will do the ultrasound fast for the pericardium very early, even before the CPR is started, because we know sometimes the CPR itself is the cause of the pericardial collection, so it will be a confounding factor later on. And to have a very low threshold for an IJV intervention, because the peripheral veins will be collapsed and the chest will be occupied by the CPR, so a low threshold for an IJV channelization. Thank you.
Thank you very much. Let's see. CHS, Ms. Brown, your comments, please. And Dr. Kaufman, would you like to comment?
I'm in agreement with what's been said before.
Thank you, ma'am. So before we return it to our
So Gary, just a quick comment. So what Dr. Puss said is very real. So I had two patients that remember that found cardiac arrest, and then I did put an ultrasound on the heart view, and then the patient had tamponade, and I quick released the tamponade, and the patient came back. So the patient's bleeding somewhere, but tamponade is a good exclusion criteria, exclusion diagnosis here in this case, and or other retroperitoneal bleeding. But you have a critical patient in front of us. I'm very curious to see how Dr. Alex manages this situation. Thank you.
Thank you. Dr. Alex, back to you.
Okay, so those are all great comments. I placed the right subclavian cordis. It wasn't easy with the CPR in progress. Probably an IO might have been a better, easier, quicker way. We started giving blood with the aim to do a massive transfusion protocol. The fast, so the ultrasound, I asked them to bring me the ultrasound from the trauma bay, from the ER. There was another ultrasound that was in the anesthesia area, but they were using that for a nerve block, so I did not have access to that one. So I was waiting to get the one from the ER. At this point, CPR continues. There's no return of circulation. We're probably 10 minutes into the code now. The patient went from asystole to PEA. So right now, I'm still waiting for the fast. How do I want to proceed? Continue with CPR for how long, and what are other options? A couple of weeks ago, Dr. Niels Martin just presented something interesting on a Reboa used for a gunshot wound to the extremity. So is that something that would be considered? So how do you want to proceed now?
Sadler, are you prepared to comment at this time? You're muted, Sadler. Your mic is muted.
How do we undo this?
Okay, you're good. Go ahead.
You got it? Okay. Sounds like you might have to just do some interventions to try and relieve the PEA. So, someone mentioned earlier about the tension pneumothorax. Hopefully you could pick up on that. I know it's hard to necessarily hear that in the middle of the code, but if you have any kind of clues on your physical exam, then I would consider putting chest tube on that side. And if you're not sure, you may end up just having to do both sides. And then we talked about that possibility of pericardial tamponade. So it wouldn't be unreasonable to try and relieve that if you thought that was the cause.
How are you going to do it?
If it's intra-abdominal and you're concerned about that, you don't have fast scan available, then even though we don't utilize it much anymore, you could potentially do a DPL, look for frank blood or gross contamination.
Thank you very much. In Qatar, Dr. Rizzoli?
Yes. I wouldn't change much at this time. I would still continue doing CPR nonstop. First of all, this just happened in front of me. This is iatrogenic, most likely. So I would not stop at all. I would continue doing all the CPR, following all the standard protocols, and I would be asking for information. One of the beautiful things that I like in the United States and in North America is that people usually document what they do. They have stickers if they put grafts or if they put something different in someone's body. So I would try to get as much information as possible about what has been done to this patient. And because I'm a surgeon too, usually my solution to all the problems is surgery, I would also be saying that maybe we should consider making sure that the OR has a room open in case we have to rush this patient to the operating room. Thank you.
Thank you, Dr. Rizzoli. Sao Paulo, Dr. Calais, your comment, sir.
Yes, I agree with the comments, but I think it's one problem. To put Reboa in this situation is very difficult because the patient is still in cardiac arrest. So the position here for me to put a Reboa here is very difficult because I don't have the catheter, the small catheter that I can go to the cushion. If I know this patient has signs of cardiac tamponade, he has stars jugular, he has some things that can be helpful for that's an injury of the pericardium, hemopericardium, that's a complication of catheterism is obvious. I think that I go to in this situation, I don't have a Reboa. I go to maybe if in extremis, I go to a thoracotomy, anterolateral thoracotomy in the room, and try to fix it, to fix if there is a pericardial tamponade, I realize, and then go to fix the injuries that I have it, or I can go aorta cross clamping. So there is a problem. It's very important. Okay.
Thank you, Dr. Okay, great. Thank you, Dr. Calais. Dr. Frisbee, your comment, sir?
I think I like Rizzoli's idea. This lady dropped right in front of you. Don't change anything right now. Let's just keep moving and make another phone call or have somebody do it to get that fast machine in there. Get your ultrasound so you don't do a needless thoracotomy. But the point is, you know, just keep doing what you need to do. It's not time to do anything else right now. That's my only comment.
Thank you, Dr. Frisbee. In Norfolk, Dr. Grigsby, your comment, sir.
Yeah, it sounds like we need to keep on working on hydrating, resuscitating this patient. Would like to get the ultrasound machine, look at the heart. Again, empirically kind of given calcium and bicarb, that kind of thing. And then, yeah, I also agree, you know, I would like the bilateral chest tubes if we can't get breath sounds, but you know, this is still earlier on, so we need to keep on resuscitating and see where we get out. In the meantime, the person who did the procedure needs to show up.
Thank you. Dr. Hakeem?
Yes, I do agree with the comments. Probably bilateral chest tubes, continue with the CPR, and get the fast machine as quickly as possible. Thank you.
Thank you. And Dr. Poost?
Yeah, I agree with what everything was been said already. Would be nice to make the differential diagnosis. I think the prior comment of looking for clinical signs of tamponade is very important, because if you have distended jugular veins, you know, it points more towards tamponade, and then what has been said, the next move would be to do a thoracotomy. But it would be nice to get the ultrasound. But if you can, right, at some point you have to make a decision, because you're already 10 minutes in here, and as long as it takes, as long as you're in your rest, least likely you're going to get this patient back. So, you know, I think there comes a point where you just have to bite the bullet. And so probably thoracotomy, if you can't get the ultrasound now, would be the next step to do, as mentioned before. Because even if it's a retroperitoneal bleed, yeah, at least you can clamp the aorta and stop it. But those retroperitoneal bleeds, you know, usually progress over time, right? So it's not like that you get an immediate effect. And just doing a thoracotomy for a retroperitoneal bleed, that would be a high price you paid, right? So you know, you're hoping obviously that if you do a thoracotomy, you find a cardiac injury, but you know, the answer would be the ultrasound. But if you can't have it, at some point you just have to commit and go for it. And to do a rebore could make it worse if you have, first of all, you don't know what type of injury you have. You don't know where it's perforated in the retroperitoneum, number one. And number two, if you have a cardiac injury and you tamponade that and now you put a balloon in the aorta, you may make it worse because you're increasing the afterload. So I think, you know, if you can't get the ultrasound right now, I would go for thoracotomy.
Very good, Doctor.
Thank you, Dr. Poos. Any other comments before we return to Dr. Alex? Go ahead, Dr. Alex.
So yes, I actually committed. I couldn't wait anymore for that ultrasound, and as everybody's comments were, you know, if it's cardiac tamponade, it needs to be released. If it's an injury to a major vessel, then with the patient in arrest, then this is a trauma to, I don't know, renal artery or iliac or something in the retroperitoneum. And with the patient arresting, helping with the perfusion and clamping the aorta would be helpful in this situation. So I opened the left chest. We rolled to the operating room as compressions were in progress and she was getting blood. I opened the pericardium. I placed an aortic cross clamp. I started open cardiac massage. The heart appeared that it was fibrillating a little bit. These are not pictures from the case, but a couple of points about opening the pericardium. I was able to pinch it with the finger and even like grab it with the bakies and cut it with scissors. And that's usually a good sign. It's, you know, there was no tamponade usually when it stands. You're not able to pinch it, open it easily. You just have to cut it with the knife. The aorta appeared very, no hematoma, nothing in the chest, but just like one of those, you know, Italian pasta, just really flask and just the patient emptied somewhere all that blood. And I performed cardiac massage. She already had a couple of rounds of epi from the recovery room. And with the blood, I ended up using internal defibrillator, and then I obtained, after one shock, organized cardiac perfusing rhythm, blood pressure in the mid-90s, over 60s, and heart rate 78. The on-call surgeon arrives now, so I have some extra help, and the interventional cardiologist comes and tells that he did a right common iliac artery stent placement for a patient with claudication and severe stenosis. So at this point, how would you want to proceed with regards to the iliac artery? Proceed with laparotomy, or would you just go and do a right retroperitoneal approach?
Bangkok, Dr. Supa, would you like to comment, sir?
Thank you, Gary. May I ask what was the mechanism of injury again in this lady? It was blunt injury?
There was angioplasty and some sort of a stent placement in the catheterization lab, and the patient basically arrested in the recovery room.
I see. Okay. So in this case, I would think about retroperitoneal bleeding, like lots of our friends mentioned before. And this lady, I think the next step is to perform laparotomy. We should move her to the OR and do the laparotomy in the OR. And while if you keep the aortic cross clamping in place, it should help with her blood pressure. Thank you very much.
Thank you.
Thank you, Dr. Supa. Qatar, Dr. Peralta, your comment, sir? You're muted, Dr.
Okay. Great case. I go with the same approach. I open the abdomen, okay, and from there I can you know, reassess and do a proximal and distal control of the probably injured vessels that she has already. And of course, she is in the MTP going on, you know, and that was great. And probably I can move the clamp down to the abdomen of the aorta. It will be better perfusion.
Thank you, Dr. Peralta. Dr. Hakeem, your comment, sir?
Go with the laparotomy. Thank you.
Thank you. Dr. Calais, Sao Paulo, your comments, please.
Yes, I agree with the comments. I go to laparotomy and change the clamping or the aorta clamping.
Thank you, Dr. Calais. To Ryder, Dr. Poost.
Yeah, I agree. I would do the same thing, laparotomy. It theoretically could be also doing a retroperitoneal or extraperitoneal approach, like the kidney transplant incision. The problem is we're not doing it every day, so you're probably faster going through the abdomen. So I would also do the laparotomy.
Thank you, Dr. Poost. Dr. Eidenberg, Sadler, your comments, please.
He agrees. He would do a laparotomy and then change the aortic cross clamp into the abdomen for more control.
Thank you very much. Back to Qatar, Dr. Rizzoli, your comments, please.
Well, I think there's no way for half measures or for different approaches or for small incisions. These patients in cardiac arrest, I agree completely. And actually, I want to congratulate you. You're a brave surgeon, right? The opening without having the ultrasound and perfect intervention. So I can tell so far that you saved this patient life, but that's it. Keep the cross clamp, patient goes to the OR, open the abdomen, and deals directly with the bleed.
Thank you, Dr. Rizzoli. Dr. Frisbee, who's with us in Miami today, your comments, please.
I think Rizzoli's right. I think if you're going to be a bear, you need to be a grizzly. That's a good way to do it. I would open the abdomen now and get proximal and distal control. Nice job.
Thank you, Dr. Frisbee. In Norfolk, Dr. Grigsby, your comments, please.
Yeah, so I agree with everyone saying so far. We can open, wouldn't waste time on something fancy like retroperitoneal dissection. We'd just go midline. We talked a little bit about, they get an RCI, a right common iliac stent placement, but haven't mentioned where his access was. We got to think about, that's the other area where he may have an issue. So it may actually be the issues on the left side where the access was. But then, yeah, like move the cross clamp down, proximal distal control, and do the repair.
Thank you, sir. Any other comments before we return to our presenter? Okay, back to you, Dr. Alex.
Okay, yeah, so I did go and I performed laparotomy. I encountered hemoperitoneum and just swelling in the right side, the pelvic wall where there was a hematoma. I found a distal right common iliac anterior wall perforation. It was just proximal to the external and internal bifurcation. Proximal distal control was achieved. The aortic cross clamp was slowly released. We also used a sponge stick to, press down on the aorta. I didn't have I had an extra set of hands, but it would have always be good to have some more to, hold the pressure and help with everything. But I was able to get proximal distal control. And just to kind of here with black is kind of where the stent was sitting. Got control here, control right here below, and it was maybe 1.5 centimeters perforation in the anterior wall. So how should we proceed? How would you proceed now? Call vascular surgeon. Now, what if you don't have a vascular surgeon and you need to do the repair yourself? What options and how would you approach this?
Thank you, Dr. Alex. Dr. Frisbee?
Patch that hole. Don't worry about the vascular surgeon. If you found the defect and it's not more than 50%, you need to patch that hole.
Okay.
That's all I got.
Thank you, Dr. Frisbee. And Dr. Grigsby?
Yeah, just ask for the bovine pericardium. Make sure you're doing that during the dissection. And then we can work towards a patch. That's all I have to add.
Thank you, Dr. Grigsby. Qatar, Dr. Peralta, your comments, please.
Great. We're lucky. We already have this patient alive. This patient already is approached from the belly. Instant damage control, you find the injury. If it's like that, like less than 50%, I probably patch. We always call vascular surgeon here, but if you have no vascular surgeon, just patch is the right way to go.
Thank you, Dr. Peralta. Sao Paulo, Dr. Calais.
Yes. Usually, I believe that it's very important in this case to call for the vascular surgeon, because this is a normal iliac artery. He has a stent and he has a perforation. He has probably arterial disease of this artery. So a simple patch may be not adequate for close this injury. In these situations, you can make only a damage control and put only a stent, not a temporary stent, and a shunt, or temporary shunt, and then call for vascular. Review the patient's next step, because the patient has a cardiac arrest, the patient has unstable iliac artery is a disease iliac artery. So sometimes they put the repair is not very good, because the arteriosclerotic of the artery is very difficult to repair. So in this situation, I think that it's very good to put a damage control artery in this moment, and then call for vascular to review the artery. Or if you can do anything, you can I believe in this situation, have a stent, open the artery up the injury, you have to repair all the artery. So you have to make a stent of the artery, can put a stent near to complete or close the hole. By endovascular surgery, during the surgery can put, and sometimes other procedures. But I believe you have to be very different in these situations. It's very different injuries for the artery, of the traumatic injuries of the artery by a gunshot wound or other situations. So I believe in this moment the patient has unstable. I believe this patient need to make a damage control in this artery, put a temporary stent, and call for the vascular surgery. Thank you.
Thank you, Dr. Calais. And Sadler, your comments, please.
We would agree with damage control surgery. The safest place for this woman right now is to get her resuscitated and correction of any kind of surgical bleeding or even coagulopathic bleeding at this time, and get her into the intensive care unit. I think that would be a safer, and then have a vascular surgeon come in and figure out how to repair this complex injury.
Thank you, Sadler. Dr. Hakeem?
I would try to repair it and wait for the vascular surgeon.
Thank you, Dr. Hakeem. Dr. Super, your comments, please.
I agree with a damage control principle in this patient, but I think the easiest thing to do at this point is to just stop the bleeding by primary repair. And if I cannot stop the bleeding by primary repair, I may even do the ligation of the artery. Putting shunt in this case may be difficult because we have a stent in the proximal artery, and the stent may not suitable for a graft insertion. You cannot snap the graft tightly to the stent. And after the repair and the bleeding stop, I will take the patient to ICU for resuscitation and ask the vascular surgeon to evaluate the patient later. If there is problem with lymph perfusion on the right, we can come back later on the second operation when the physiology is corrected. Like we can perform simple operation like femoral bypass, but after the patient is well resuscitated. Thank you very much.
Thank you, Dr. Super. Ryder, Dr. Poos, your comments, please.
Yeah, I agree with what Super just said, and also our colleagues in Sao Paulo. I think it won't be that straightforward to just patch it with a very calcified artery, a stent in place, the rupture, I don't know if it's just proximal to the stent, so it's a very difficult situation. And on top of it, you have a very sick patient. So I also agree, you know, damage control is probably the way to go here. Now the question is if you can get a shunt in or not. That's a good point. So it may be difficult even to place a shunt. But if I can place a shunt, that's what I would do, and wait for the patient to physiologically get better. And I agree, you know, I think vascular surgery input is a good point here, because it's a very not normal artery, number one. And number two, you know, this patient had a major complication from an elective procedure. So also from a legal point of view, at least, you know, in the United States, it's probably advisable to bring experts in when you have them available, you know, on the reconstruction. But I would do first the damage control. And it's a good point, right? Worst case scenario, Super is right. I mean, worst case scenario, you could really ligate it. And then if necessary, do a fem for the other side, cross over to perfuse if it's a very diseased artery and you cannot shunt or repair it. So very good points you guys made.
Thank you, Dr. Poost. Any other comments before we proceed? Thank you. Dr. Alex, back to you, please.
So yeah, I agree with all the comments. Thank you for your input. So theoretical option would be just, you know, remove all this portion and then put a new piece of graft, or do ligation and do a fem-fem. But always less is more. So, and the other thing that was unknown, what's the neurological status here? And I didn't know that. And before you go on a complicated repair. So what I ended up doing, I just did the primary repair of the common iliac artery with 5-oproline. Basically what I did, I just put a Cooley clamp kind of across here. It narrowed more distally, but it was kind of like at a 50%. And basically before that, I released the proximal and the distal clamp, and I had back bleeding on each side. I flushed with heparin. Then I put my let me find my mouse here. Then I put my, you know, Cooley clamp here, and then I ran a Prolene from one end right on top of the clamp, and then back towards where I started at the top, and then I released the clamp. I felt by palpation that there was flow here distally where I'm with the mouse, and then I asked somebody in the operating room to go under the drapes with a Doppler and see what's going on. But both feet were cold. On the left, there was monophasic on dorsalis pedis and tibialis posterior flow, and then on the right I had monophasic tibialis posterior. So with also not knowing the neurological status, I was satisfied that this patient is not bleeding now, and there is flow distally until I get more input from a vascular surgeon. So we proceeded with the closure of the thoracotomy. I left 2 chest tubes on the left. I closed the laparotomy. Because we didn't do any count when we opened and it was crazy, we got a chest x-ray and an abdominal x-ray because of the counts, and found a 20% pneumothorax on the right chest, which was probably from my cordis. Here is where the pneumothorax is on where the red arrow is, and my cordis line just really right above here. And it was not easy to do this with chest compressions. You know, other option would have been, okay, if I put an intraosseous in the right humerus, it would be fine. I would have avoided the pneumothorax. If I would have if that would have ended up being in the left humerus, that would have interfered with moving the arm up above the head for the thoracotomy. And then the tip of the acromion dislodges the intraosseous. So I wish I would have maybe utilized the IO. We're in the ICU now. And yes, this patient needed resuscitation, and she was still intubated. The first day, the chest tube was leaking. So a repeat x-ray showed that the sentinel hole was outside of the chest. So I placed a new chest tube. She was still on a little bit of levofed. The right lower extremity was cold, colder than the left. And I still had that monophasic tibialis posterior. CPKs were slightly elevated. The patient started following commands. So at this point, I took it as I have a viable, patient with good neurologic status. And I decided to look down further into what's going on in the pelvis with the iliac artery. So I did a CT angio of the abdomen and pelvis, which showed that the distal portion of the right common iliac stent was partially collapsed. There is loss of flow in the right external iliac due to occlusion, but it reconstitutes distal in the right common femoral artery. I also added the chest of the CAT scan. So for the sentinel hole being outside of the chest, I put a new chest tube here, still had a little bit of pneumo, and that's why I did the chest tube added to the CT angiogram. We can see here where the arrow is, where the stent is partially collapsed. Again, the arrow shows where there is no flow in that segment of the external iliac artery. But I must have locked out a little bit because there is reconstitution of flow in the common femoral artery distally. So she also had a big subQ emphysema on the right side where I put my line in the chest tube. And at this point, what should be done about the short segment with absent flow in the external iliac artery in the situation of the CT angiogram findings, and how would you manage this persistent air leak? So now this case happened on Friday. I have this information on Saturday. Vascular surgeon will be available on Monday, but he is available by phone to discuss the findings. So how would you proceed?
Dr. Hakim, your comment, sir? Go ahead, Dr. Hakim.
Yeah, a difficult situation. I don't know. I mean, you have to keep in view the ischemia of the lower limb, the compartment issues, but it's a very difficult and tight situation. Thank you.
Thank you, sir. Ryder, Dr. Poos, your comment, sir.
Yeah, first of all, I mean, it's amazing that her neurological status is intact and stuff. That's great. So from the leg, I mean, it seems to me like it's perfused, meaning like you're not going to have necrosis of the limb, right? I mean, there's flow, there's distal reconstitution, so there's flow to the leg. You have to be monitoring for compartment syndrome, obviously. You know, if that's the case, then you would need to do fasciotomies. But as long as the leg is perfused and you have a signal distal and there's contrast, I would hold off on doing anything right now. I think it's mainly going to be a claudication issue if she recovers, and then she can have an elective reconstruction. Most likely it's going to be a fem crossover. I don't think many people would go back to that area again anytime soon. So, you know, from now, I just would sit tight and wait. And regarding the air leak on the chest, and just, you know, you have put a reposition and you put your chest tube and just wait. And regarding the interosseous and stuff, that's all good point. Interosseous is a great access for medication. You can transfuse through it, but you know the flow rate you're going to get is not the same as you're going to get with a cord that's close to the heart when you go on a massive transfusion protocol. And key here is the only reason why you got her back is because we were very aggressive. You did open heart massage. Remember, CPR on a patient who is exsanguinated is very ineffective. Right? So the reason why she came back quickly once you open it is because you had a good central access. You give her blood fast, which came close to the heart. You start to get filling again. You massaged her and you perfused the coronaries. And that's why she went back into VFib, and then you could shock her and you got her back. So I don't think necessarily the central access was a mistake or worse than interosseous. I think it actually what saved her life. And yeah, she got pneumothorax on the side, but hey, you know, again, what was key here is to restore perfusion as fast as possible, because otherwise you would have, you know, go the scenario down with brain edema, brain death down the road. So I think you did everything right here.
Thank you, Dr. Poos. Qatar, Dr. Rizzoli, your comments, please. You're muted, sir.
I agree completely what Dr. Poos said. I would definitely talk to the vascular surgeon. This is a complex issue. I would at least have his or her input. I would show the image and discuss. I would also by now have done a CT of the brain and seeing if there will be any contraindication for anticoagulation, which I suspect might be a recommendation from the vascular surgeon. The air leak is a well-managed new chest tube, I would wait. Seems like something that we could follow as the case progress. And I agree with Dr. Poo's comments on the access. I think that so far you have done everything perfectly, and the patient is still alive, and now we're concerned about the leg only, thanks to your surgical bravery, or correct one.
Thank you, Dr. Rizzoli. In Bangkok, Dr. Super.
I agree with a previous comment from Dr. Pus and Dr. Rizzoli. And I think you did a wonderful job bringing this lady back. And that's it.
Thank you, Dr. Super. Dr. Grigsby in Norfolk.
Yeah, just to add, we've got contrast on the CTA distally. There is some flow. You may have some issues with the toes and stuff like that, but giving the patient time to recover and be able to tolerate the surgery she needs, and then if you are pressed, doing a fem something quicker, she might be able to get a different surgery in a month or two. And then, yeah, she needs a chest tube. Yeah, that's all I really have to say.
Okay. Thank you, Dr. Grigsby. Sather, your comments, please.
Yeah, not a whole lot to add. I think we kind of echo what's already been said, is that I would try and work closely with vascular surgeon. I might consider discussing the possibility of interventional radiology, trying to help open up that stent a bit to improve flow, and certainly try and keep her on anticoagulation and maintain good flow to that foot until something more definitive can be done by vascular surgery.
Thank you very much. I'm sorry, sir, were you finished?
I was saying that's it. Thank you.
Okay, thank you. Dr. Frisbee, your comments, please.
Oh, I just have one. You said you had reconstitution distal to the stenosis. That denotes a chronic condition in my mind. I think Poost is right. I think you're going to have a claudication issue more than anything. That's all I've got. Thank you very much.
Thank you, Dr. Frisbee. Sao Paulo, Dr. Collet.
Yes, I agree with all the comments. I believe that in the artery injuries that you can see, they can see the femoral artery is with the contrast. So at this moment, you can wait. And sometimes the patients have signs of compartmental syndrome. I go to the fasciotomy and then and wait for the vascular surgery, because we have several techniques to repair these conditions in the chronic artery injury. So I believe in the chest, you can management at this moment only with the chest tube. Thank you.
Thank you, Dr. Collet. Just noticed the raised hand icon from Qatar, Dr. Peralta. Thank you, sir. Go ahead.
Yes, Dr. Collet just took my word. I would say if the CPK is still raising, I probably want to do a fasciotomy, because you want to make sure that this collateral circulation doesn't collapse because of compartment pressure. And great case, great job.
Thank you, Dr. Peralta. Any other comments before we proceed? Okay, Dr. Alex.
Thank you. So I followed, her exam, extremity, repeat CPK. They were actually, started to trend down slowly. As she came off pressors, she actually had a palpable tibialis posterior on the right lower extremity. She was still intubated when, with regards to the right chest and the worsening subacute emphysema, I placed a second chest tube of pigtail. Vascular surgery, whom I talked to, and he was actually back on Sunday, and he reviewed the scans and everything. We talked over the phone, and he said there's no intervention to be done at this time, given what this patient has been through, and I agree with that. And compartments were soft, so no need for a fasciotomy, but I was constantly monitoring and checking the patient. With regards to the anticoagulation, So she had some consumption coagulopathy, her platelets dropped. She was fully loaded with Plavix before and aspirin. And I sat tight for a couple of days. And when her platelets started going back up, then I added the Plavix, just the Plavix through the NG tube, again, talking with vascular surgery over the phone. This is the pigtail that I placed here. That cord is really kind of made me suffer a little bit. But as everybody else said, it was good to have an access above, central access, and help giving the blood straight to the heart. Actually, what helped with the pneumothorax was really being able to get this patient extubated on day 6, and her left chest tubes were removed. She still had the right chest tubes, but the sub-Q emphysema and the air leak started resolving. She was slowly getting to a regular diet. By next couple of days, her acute kidney injury resolved. Foley catheter came out. She was then transferred to IMC on day 11 without one of the chest tubes, on regular diet, voiding. She was discharged home with home PT and follow up with vascular surgery and trauma surgery. Thank you. Any final comments?
Qatar, Dr.
Yes, Alex.
I'm sorry. Go ahead, Dr. Post.
Alex, congratulations for this tremendous save. I mean, it's really remarkable to think that this patient went home in 2 weeks with no neurological deficits. And there's only one reason for that. And that's because you were brave enough to make a very difficult decision early on and go full press with a thoracotomy, to control the bleeding and reperfuse the coronaries and reperfuse the heart and get her back early on. And we see this over and over again, right? We have people who are exsanguinated or tamponade and they get prolonged CPR without addressing the underlying cause early on. And then they end up with, prolonged brain ischemia, brain swelling, and poor neurological outcome or die. So it was a very brave decision you made to go full press after a patient who had a fairly minor elective procedure resulting in cardiac arrest. To really go and say, like, I'm going to do thoracotomy, I'm going to do a laparotomy and do all that is remarkable. So really congratulations to getting her back and for saving her and get her home in 2 weeks. It's incredible, number one. And then number two is also as a little reminder, it's great to work in a trauma center. It's not a one-man show. You got the resources where you got the MTP, you got a good anesthesia team, you got all the people you need to pull something off like this. So it's really fantastic. Congratulations. Very well done.
Thank you, Dr. Post. Qatar, Dr. Rizzoli, your final comments, please.
Again, I have to agree with Dr. Post. This was a excellent managed case. Like, there was no hesitancy in doing the right thing, and it was a thoracotomy, and any hesitancy in here would result in delay, that would result in death of brain cells, and a very much different outcome. So I think that it's a fantastic choice and the correct one, and very well done. Thank you for presenting this very interesting case.
Thank you, Dr. Rizzoli.
Thank you, Dr. Rizzoli. Dr. Hakim, your final comments, please.
Yeah, thanks for the great presentation and congrats for saving this patient. I have 3 comments quickly. One, that should we go for a neck cannulation in a CPR ongoing in a patient of cardiac arrest rather than the chest? One. Number 2, that as trauma surgeons in a level 2 or level 3 trauma centers, probably we should be more courageous to tackle the things ourselves rather than delaying the proper treatment. And the third, on a lighter note, I mean, since the right lower limb vascularization was a concern for you 3 days, I think you should have dragged in the interventional cardiologist, because this was a chronic issue which was there before this injury had occurred. So 50% of the burden of that stress on his shoulders. Thanks.
Yeah, he actually followed along, and since he came in the operating room and after we got her back, he followed. He definitely, yeah, he had a complication, and he was happy that things end up going well. But yeah, he did follow. Yeah.
And back to Qatar, Dr. Peralta, please.
Congratulations, Alex. I'm just going to tell you in your language. Wimitor, multumes, forte molt. Thank you, and an excellent case, okay? Thanks a lot.
Mulțumesc, thank you.
Yeah.
Thank you, Dr. Peralta. Norfolk, Dr. Grisby, your final comments, please.
Nothing really to add. This is a great case and a great save. Definitely good conversation. So, but congratulations on a good case.
Thank you, Dr. Grigsby. Sadler, your final comments, please.
Terrible case, but great execution and effort and great save. Congratulations.
Thank you.
Thank you. And Dr. Supa in Bangkok, your final comments, sir.
Thank you very much, Dr. Alex, for presenting this case to us. We learned a lot from your excellent management, and congratulations on saving one more life. Thank you very much.
Dr. Supa, I have a question for you. Any chance you can present the case on June 1st?
Let me check, Dr. Matos. June 1st, you say?
June 1st, in 2 weeks.
June 1st. It's going to be on 8 a.m., right?
Yes, correct.
June 1st. Yes, I think I can, Dr. Matos.
Perfect. Thank you, Supa.
Okay.
I'm looking forward for a great case as usual. Thank you.
You're welcome, sir.
And for those of us who need it, please allow me to direct your attention to your screen where the CME code is.
Yes, Gary, just a final comment here also. This meeting has been going for 10 years. So as you can see, it's a great worldwide collaboration in education. You have hospitals, physicians, surgeons, all the healthcare professionals from around the globe connected to for more than 10 years. And we continue going. So I would like to say thank you very much for everybody who has been connecting. Like Dr. Cole has been connected since day one. The guys from Unicamp also. And Dr. Suparak was connected first initially from Miami, then connected afterwards from Thailand when he came back. And I'm very glad to see Alex present his case for the first time. And I'm very glad to see his progress in his career. Thank you, Alex. Great case. You did a extremely good job. Thank you.
Thank you for training me.
My pleasure.
Thank you for the great presentation, Dr. Alex. Thank you to all the participants for joining us. We look forward to seeing you on Wednesday at noon Eastern Time. Meantime, take good care of yourselves.